and get started with today's Stretch 2.0 cohort practical application workshop. Very excited to see so many of you on the line joining us today. So for our practical application workshop today, we'll start off with a few announcements. Then we have our colleagues from Frameworks Institute joining us for their second session. So very excited to have them on the line and continue the great discussion. And then we'll wrap up with the practical application workshop evaluation. So a few little housekeeping items that my colleague Erin will include in the chat for us. So please join by video if possible and mute your line when not speaking. For our evaluators, it's very helpful for them if you please add your 2-letter state abbreviation to your name in the Zoom, which I actually did not do. I'm going to go ahead and do that here in a moment. And so reach out to us if you need any help with that, but you can just hover over your image in the Zoom platform and click on the 3 little dots or the burger, and that will allow you to rename. You should see that at the bottom of that menu. Feel free to use the chat function to add your questions or comments, and this meeting is being recorded. So Erin, if we could also please hit record. Okay, and so this slide is again just a reminder of where we are in the arc or the journey for this Stretch 2.0 cohort. So again, what you see on this slide are the 6 conditions of systems change and how our practical application workshop partners capacity building activities fit into this model. And so we are at the bottom of the model, with Frameworks Institute addressing mental models. And so as we'll be moving up with our other partners, Ovation and Boundary Spanning Leadership, they'll be addressing relational change. And then Georgia Health Policy Center will be addressing the structural change pieces. And on to our announcements. So last time in our July meeting, folks responded in the evaluation stating that they were looking for more time to practice the learnings and discuss them. And you all also suggested more small group activities, more time for Q&A, and sharing more resources, such as examples and videos as ways to apply what you learned. And so we're super happy to share with you all that you can have these opportunities and receive additional technical assistance from our wonderful practical application workshop partners, such as Frameworks Institute. So in our September cohort newsletter, you'll be receiving a document on what TA is available from each of our partners, and then how to request that technical assistance. So that document will also be housed on the Stretch cohort SharePoint site. But overall, you'll be working with your core teams to request that technical assistance and get more of that kind of hands-on experiences with our partners. And then additionally, we are in the early planning stages of our culminating kind of final event, which is the Stretch 2.0 Summit. This is going to be an in-person event, but in Phoenix, Arizona on March 10th and 11th. And so we're also considering a hybrid meeting option for those that will not be attending in person. And so Erin will be dropping a link in the chat for you all. So for those of you that are not joining in person, we're gathering your interest in potentially attending some virtual sessions. So if you have a minute during the session today, please fill out that form. If not, that will also be shared with you all in our September newsletter. And then last announcement before I pass it on to Julie is that we just opened registration for our next national convening, and that is called Grounding Leadership and Engagement in Psychological Safety to Promote a Culture of Equity. This will take place on Wednesday, September 18th from 4 to 5:30 p.m. And this virtual convening will include an interactive presentation by our colleague from ASTO, Dr. Alicia Justice, that focuses on psychological safety and how this occupational practice supports an equitable workplace. Participants will leave with an enhanced understanding of how to promote a psychologically safe work environment and ultimately operationalize a culture of equity. The event is free and open to all of those who are interested, so not just the stretch cohort. It's open to everyone, especially for those who are interested in developing a deeper understanding of psychological safety, learning about best practices, and gaining a network of health equity practitioners to share experiences and lessons learned. And my colleague Erin will also be dropping that into the chat, and that, again, keep an eye out on your inbox for the registration for that, and you can share that with colleagues as well. And so with that, I will pass it over to Julie.
Thank you so much, Dorothy. Let me take one moment to push the magic button. There we go. All right. Thank you as well for highlighting some of the feedback from our partners on the call. We also took a look at the poll responses from at the end of last session and shifted our plans topic just a little bit here to be more responsive to some requests for more examples on how to talk about child and maternal health in particular, and framing with disparities data. So we've kind of integrated those into this topic. And so here we go. We're going to talk about how to put pregnancy-related disparities data in context. I know each of you, all of you, are working in settings where, nationally, we see while most pregnancies, right, are safe and healthy, and we get a healthy mom and baby on the other end of the experience. It is also true, right, that maternal deaths in particular are on the rise, and within those deaths, we are seeing stark racial and ethnic disparities, and so we need to solve these problems. We can't solve these problems without talking about them, but the way we talk about them matters. So we're going to just reset that, when we're talking about framing, and when we're framing this issue in particular, the choices we make and how we present ideas are going to lead to measurable differences in how people respond. We need to make these our choices strategically and intentionally and apply them consistently, because framing is one thing that can help us move the mental models that are in the way of creating systems and structures where people are healthy before, during, and after pregnancy, and across the life course. And so we talked about these a little bit last time, but I'll just reset quickly. If we aren't explaining things well, if we aren't framing the issues in powerful ways, people will default to the ways they're used to thinking about lots of health issues and many social issues. Individualism, that it's all about that person's choice lifestyle, maybe their genetics. Otherism, that problems are problems in some communities because of problems with those communities, a very us versus them kind of explanation. Or fatalism, that our problems are too big to solve, and there's little we can do to change matters. We want to frame in ways that don't reinforce those, or don't leave a lot of room for those, and instead we want to frame in ways that build up alternative mindsets. The idea that context matters. It's not just a matter of individualism, it's individuals in context. What surrounds us shapes us. It's not a matter of us versus them or otherism. It's more about togetherism, that we can work together towards equity and equality. And we don't need to just throw up our hands. We can roll up our sleeves and get to work. We designed the system. So if it's producing outcomes we're not happy with, we can redesign it, because these are things that we have set up so we can reset them. So that's the 3-minute refresher on framing, but we're going to get into some topics about changing the conversation on and just communicating more effectively about child and maternal health particularly. So one point I'll make is about plainer language, accessible and relatable terms. Another is around the attribution of responsibility, which is just a critical framing strategy, framing practice. And then finally, how to talk about solutions. Right, so I'm sure you can raise your digital hand if you like. If we were in the room, I bet I'd see a lot of them. If you've gotten, kind of some training or the message, right, that we need to use plain language, and the reasons for this, are many. It's good government practice and makes things more accessible to a wider number of people. And I'll add to this that if we are looking to shift those mental models at the bottom of the systems change pyramid, we really need to be talking in ways that anyone can understand. Not only, right, we can't use the language that we use when we talk to each other while we are trying to do that mindset shift work. So as a linguist, I'm a fan of virtually all forms of language. I think if we've got a way of talking about things, they exist for a reason. And jargon gets a bad rap often, but just looking at it from a broader perspective of language, it exists for a reason. It exists so that experts and people close to an issue can communicate more efficiently, right? You can pack more ideas into a shorter space. You can use kind of agreed upon, insider terms to get to the harder work more quickly, right? Because we've labeled a whole bunch of stuff with one word, and now we can get into the nuance. So, our research-based language, our typical public health speak, it has a role, and it's a role of helping us do our work with more clarity and power and efficiency. But when we are doing the work of communicating in ways to shift those mindsets, we've got to make a shift. So here, is an example of information. I recently did a review of a few different states, different reports on maternal and child health, and particularly maternal death outcomes, and looked at and saw a statement like this one in almost every state. So if somebody from Missouri is on the call today, we're not picking on Missouri. Every state has a sentence very similar to this, and it's talking about kind of how within the structure, right, of public health, what was the charge, for a pregnancy-related commission. That information is important in some places to some people. But when we're talking with the public, we need to rethink the habit of telling people, how the bureaucracy responded and where we put the problem in our bureaucracy, and instead speak in ways that show how we as fellow community members responded, right? Communicate in ways that share a connection to everyday experiences and explicitly signal, right, that public health and our health equity work is here coming from a place of care and concern. That sense of care and concern is an essential piece in building or rebuilding trust and partnerships in the public health space with all that's gone on in the last few years. So that doesn't mean you need to wear your heart on your sleeve. It means that we would frame something a little bit more like this, that when we as public health officials in Missouri noticed an increase in pregnancy related deaths, we knew we had to take action, and then telling the story of setting up the review panel. Another version of that is translating, right, that jargon, those labels that we use for essential, important, evidence-based approaches into that plainer language. And so often we start our communications of these sorts of things with definitions, like on the left, right? So the culturally linguistically appropriate services is an important strategy for ensuring high quality maternal health care and reducing disparities in mortality and morbidity. And that's just it's simply a definition and saying what we mean by it. A different approach, a slightly different approach, is taking a step back and helping people understand why that approach is even needed. What is it that was in the public health thinking that led to, right, the gravitating to class, or developing and building out those programs. So here's the kind of, it's the thinking behind the thing, kind of message here. When communities offer programs that are tailored or appeal to expecting mothers from different cultural backgrounds, moms get the care they need in the way they need it, and we all get the benefit of healthier pregnancies, births, babies, and moms. So a sentence like the first one could come after this one, right? But there's kind of you need a sense of to say, why is it that we need this, and in a way that makes sense to folks whose mindsets we're trying to shift. Another example on that same point, which is this one is about making a kind of a policy recommendation, right? And I know many of us are in spots where we can't advocate, but we use this clever language, like, to address the health thing, we can do this policy thing, right? And so that is providing information, and allows us to put those policy ideas insert them into the conversation and keep them present in people's thinking. And that is really, really important to continue to lift up those structural policy level, community level, state level approaches. But if we just start, if we don't help people, again, invite them into our expertise a little bit with a plain language explanation, then we don't know why we need to address the connection. So a healthy mouth is part of a healthy body and a vital element of a healthy pregnancy. It sounds like something that a lot of ordinary everyday words. And to promote those healthy pregnancies, some states have required that all types of insurance treat oral health as part of overall health. So not getting into Medicaid and that sort of thing. It's just that all types of insurance need to do that. And others have made sure that women have access to dental care during pregnancy and for a year postpartum. All right, so just as and these were all about healthcare. I think it's equally important when we talk about these, our upstream public health approaches, that we are pointing out, right, that it's not just on this issue of maternal disparities in particular. Really important that we not narrow the issue to healthcare, right, and that we help people in plain language understand how we're addressing those social and ecological wider drivers of health. So here, this one is actually in Cincinnati, Ohio right now, where I grew up, doing some work here with folks in the housing sector. But I love to pull this example here from something that's local for me. Avondale is a historically Black neighborhood in Cincinnati. So Avondale's approach, this is, I won't read all this to you, I think you can read it, but it's talking about really how we want to make sure that we're addressing the systemic conditions by addressing those social determinants of health. The readability level here is 20th grade, right? It's graduate level. And we cannot address those fundamental mindsets that are just foundational and default ways of thinking, that are kind of, American culture kindergarten, right? That they're everywhere. They're very they come to them early, and they're basic thinking for most folks, right? That individualism, otherism, and fatalism. We cannot address that very rudimentary kind of level of culture with graduate level language, right? We need to really invite people in a different way. So reframed in plainer language, that Avondale's residents are working with experts from across the country, right? Which is different than cross-sector collaboration. I mean, it is, but that just different, more plainer ways to say it, to tackle problems that affect the health of moms and babies. Part of the solution is ensuring that they're receiving quality, respectful care during pregnancy, but it's just as important that people are living in healthy conditions before, during, and after pregnancy. And here working on safety and vibrancy and housing, right? So giving examples of some of those social determinants of health, naming them in plain ways rather than expecting the label to do work for us when we're with the public. All right, so overall, to make your messages easier to understand, we want to use short, everyday words. We want to break up long sentences. We want to demonstrate connection, care, and concern. We want to invite audiences into our expertise with those orienting background statements. And we want to convert our terms of art into pictures of public health practices, right? We need to give instead of our terms of art, our jargon, make things concrete, make them things that people can visualize and understand. The next point is around attribution of responsibility, but I just wanted to pause and see if there were any comments or questions and invite you to contribute to the conversation if you want to, either by putting something in the chat or we're a bit of a big group today. So if you would like to chime in, maybe raise your digital hand and we can acknowledge you. Mandy, what's up? Thank you.
Hey, this is Mandy at Able, South Carolina, and I really appreciate the explanation of plain language for the people that we serve. And also, I want to reiterate that it's going to be helpful for our colleagues as well. You mentioned that, we have certain ways of talking in the public health community or in the healthcare community. And I think as we continue to evolve and improve, that's going to mean working with more people with disabilities and including them not only as consumers, but as colleagues, as leaders. And we shouldn't assume that even if we're in a professional workspace or space, that everyone there understands things in the same way. I, for instance, don't do well with acronyms. And although I've been in this public health space a very long time, I have to interrupt meetings, and I do it now. I'm empowered to do that and ask for a definition of whatever acronym is being used. So I wanted to point that out because so much of what we do is very consumer, client centered. Like, how do we improve this for the community? But the community also includes practitioners and professionals. So I wanted to chime in with that. Thank you.
Yeah, that's a great point. Thank you for raising that. Even when we are collaborating with other professionals, right? They may not have the expertise in this thing, right? So the easier we can make something to understand, the quicker we can get to the work, right? We don't have to get around the work of translation in the moment. Any other reactions or contributions? All right. I'm going to move on to something that's, to something it's more of a fundamental framing strategy. Just like plainer language, this attribution and responsibility can be woven into your communications, all over the place. It's a really powerful, I think, approach to thinking, to shifting mindsets, but also to communicating the public health perspective on many issues. So by attribution, I mean, it's the way we explain the causes of behaviors, events, or conditions, and attribution of responsibility refers to the framing of who or what causes a problem, who or what is affected, and where responsibility for addressing that problem lies. Attribution matters in communications a lot because the way responsibility is framed has a major effect on how people think about the solutions they will see as appropriate and effective. So if we want to get to approaches that fix the conditions and aren't just predicated on we need to fix the people, this attribution of responsibility strategy really is essential to getting that kind of support for those structural solutions. Attribution, here's an example of behavioral attribution where it's attributing the outcome to the behavior of the people in the situation. I sometimes get feedback that this example is a little too extreme. No one would ever say this, but I literally took this from the New York Times not too long ago. Every year, roughly 3,600 babies in the US die suddenly for unknown reasons. Researchers estimate that if expectant moms would just quit smoking, we could prevent 800 of those deaths. So the word just, right, as it makes it seem as if it's simple and as if they're making a decision that is, frivolous, heartless, not caring, right? They are being an insufficiently protected vessel for the child, right? And it's attributing it particularly to the behavior of smoking. And so here's a different frame, and we would want to promote the understanding that it can be about access, assuming you want to talk about tobacco at all on this topic. But researchers estimate that if we connected expecting families to treatment for nicotine dependency, we could prevent 800 deaths a year. And so the responsibility here is on the system that needs to do the connecting, right? We've broadened it out a little bit, not only to the mothers, but to the families, thinking about, the home as an environment, right, where secondhand smoke exposure can occur to anyone in the room or anyone in the home. And we've made this about nicotine dependency, not the behavior of smoking. And so that's a little bit of a reframe there as well. I'm guessing that nobody in this room would write the thing on the left, although I do see on some state public health websites some things that really get kind of close to this. And so it's important to make sure we're not attributing to behaviors, but rather trying to find the places in the system that are responsible for addressing the issue. Second of all, another example, and this is, I think, more common in public health communications, is just not attributing any responsibility at all. It's just as if the problem just the problem exists. It is here, and we're not sure who caused it, what caused it, and who's responsible for it. So, in the U.S., too many women are suffering from pregnancy complications that lead to serious injury and death. Again, it doesn't say who or what's responsible for the problem or solution, and that leaves just way too much room for fatalism. What can we do about that? We can, when we attribute responsibility to systems, we give people a sense that there is something somewhere someone could do, right, to change something, and so that's pushing against that fatalism and pushing more towards that efficacy. So the U.S. is failing to manage pregnancy complications that lead to serious injury and death. So this grammatically puts the nation as the subject of the sentence. You could use your state, you could use your local area, etc. But the idea is now that there's an action that the nation is failing to take, but could take. We could manage it. And so it's a subtle shift, but often framing is about making relatively subtle or simple seeming changes in how we present those ideas that can lead to remarkable differences in how people respond. Finally, thinking about, once we are talking more about things in more specific ways, making sure that we're not only just moving responsibility from, we're not blaming mothers for people, people who are pregnant with for the issue, and just moving from the mom to blaming the providers. We want to make sure we are not just getting into the dyad of the doctor and the woman, but trying to really keep that public health perspective going and showing the upstream factors. So here's one that is I think is very well intentioned, and it is vital that we change things so that women are not experiencing subtle acts of exclusion, outright hostility, evidence of mistreatment in healthcare settings due to race and racism. So we need to address this issue, but the way we talk about it, I think, can make a big difference. So here, many women and people of color, particularly Black women, report mistreatment in healthcare settings during pregnancy and childbirth. Women report having their pain ignored, requests for help denied, or being made to accept unwanted treatment. 20% of those surveyed reported experiences of mistreatment during maternity care. This is higher, right? 30% for of Black women, 29% of Hispanic women, and 27% of multiracial women reported mistreatment. So my concern here is that this, again, it doesn't attribute responsibility, and it's just easy for us to say, well, I don't really think doctors are racist. Maybe they're busy, right? Or, you know, what are you going to do? You know what we need to do? The fix is implicit bias training, and that's the whole fix, right? So, so if we are focusing on people's behaviors, right, we get little picture solutions, but if we can get to upstream factors, we can get bigger picture solutions. So here's an example of what I might do for that. So still talking about the same issue. 1 in 5 US women report being mistreated during maternity care, with reported rates even higher among women of color. Because effective models to monitor and reduce mistreatment and bias exist, federal agencies and networks of hospitals in 49 states are working together on improving treatment and training. But right now, only 28 states receive federal funding for this vital work. So this has, it's still talking about the issue of maltreatment. It's still talking about, but it adds in solutions. And it adds in the context that, you know, we've got this network that's working on things, but that work is not fully supported. So that is pointing to a much more upstream factor than just the instance of maltreatment itself. All right, so attribution of responsibility, really, really critical. Just wanted to pause and see how that landed, people's thoughts about that, and does it about attribution of responsibility and how it might be useful. Okay, well, if we don't want to discuss that one, that is no problem. Finally, framing toward solutions. An example of this is to, this is an issue, and many of the public health issues we work on, health equity issues we work on, really are emotionally difficult, right? Once you realize, you know, kind of what people and families are going through, and so that can inspire us or nudge us to really want to say, if people only understood how bad it was, you know, how can then we would be getting different responses from people's you know, from our communities, from our audiences. But sometimes when we don't, if we are just stacking up the stark statistics, it is possible that we're sparking that fatalism, and if we aren't attributing responsibility, you know, appropriately, we can actually be reinforcing blame and stigma against the communities, right, that are experiencing the problems. So we want to make sure we're talking about solutions early and often, and that we have this tone, even if we're not naming a particular solution, have this tone and give the sense that there's stuff we can do, right? It's not just that the problem exists. It's that there's a problem and there are steps we can take to address it. So on an example, on the left of kind of failing to mention solutions, in 2019, 700 women died in the United States from pregnancy-related complications, and the numbers appear to be rising. More than 80% of pregnancy-related deaths are preventable. A slight reframe of that is to give that sense of urgency, but to change that second sentence. So I might start with the first sentence, right? In 2019, we had 700 women who died, or you could talk about the percent increase, right, in your area in order to make the numbers feel a little more relatable. But then add a sentence like this, right, to ensure that everyone has a full and fair chance for health and well-being. We can take steps that could prevent more than 80% of pregnancy-related deaths. So even just saying we can do something about 80% of this is different than using the jargon of preventable, because people don't have a sense of what prevention means in the public health sense. So anytime we can use active verbs around prevention, take steps, tackle the issue, anything that is one of those kind of lively, in action kind of verbs is going to be really helpful there. Overall, when we are talking about particularly painful issues, health issues, it's important, right, that we keep the urgency we have it. It is there. It is an ingredient in our narrative, but it is not the only, right. We add the seasoning to the narrative, to the communication. We don't give people just the spoonful of salt, right? And so really thinking about balancing that urgency and efficacy. In general, if we fail to talk about solutions and keep that efficacious tone, we are setting ourselves up for some issues, some challenges that we, some unwanted and unintended frame effects on the side. So if we are raising a big problem, particularly one rooted in racism and structural inequities, if we raise that big problem and don't mention the possibility of big solutions, we can spark or reinforce fatalistic attitudes. Also, many public health issues really can't be solved without those collective solutions. We need, structural, collaborative fixes, but people just have trouble. They don't know about them, and so they have trouble imagining them, right? So if we're not naming them for folks, then we're definitely leaving the public imagination short on fuel. And then finally, emphasizing collective solutions by definition focuses people's attention on the policy context. And that helps to reduce the tendency to blame individuals and affected communities. So I know many of us are working in settings where talking about equity has become, perhaps fraught or difficult, sometimes outright banned. I'm here to say that if you're talking about collective solutions in effective ways, that in itself is a health equity frame. If you haven't, if you're not, it's a health equity framing move. If you've done that work effectively because of what you're doing, right? You are moving things upstream, moving things further out in that socio-ecological context, and you're moving blame and responsibility, right, away from the individuals and affected communities and to systems. So the 3 points of today are talking about public health in accessible and relatable terms, attributing responsibility really carefully, and framing toward solutions. I just want to open the floor for any questions, and particularly any examples of challenges that you all have had in talking about the issue of maternal and child health. And then maybe we could, just try to respond to some of those challenges as a group.
More of a comment, really.
Yeah.
It's just telling you how much I appreciate the language that you're using, because I think it's so powerful. So I just wanted to say thank you.
Oh, well, thank you for saying that.
Yeah,
That's good.
thank you. Thank you so much for
Yeah.
making the time for this space. I think it's really important.
Well, I really pared
Hi.
down
Oh,
my presentation this time because you all were so chatty last time, and I was like, I'm going to leave room for conversation. But so, all right, good, Mandy, you're in. You're in. Go for it.
thank you.
Yeah.
I know I
Yeah.
talk a lot, but
No, it's
um,
great. That's what we're here for.
I'm
Yeah.
compelled
Yeah.
in these
Mhm.
spaces. Um, Again, like talking about our colleagues and other people in the public health sector, like we are these people, right? We
Mm,
are the people that have lost children. We are
yeah.
the people that have lost pregnancies. I'm a white woman living in the South, but I see there are Black women on here. So I don't want to overlook the fact that we are the communities that we're talking about today, or that you're talking about today.
Yeah.
And I don't want to lose that in the conversation, because while our service, our jobs are important, so are everybody that we reach. And there shouldn't be an assumption that just because we're in professional settings, that people in that room are not also included in what's being shared. It's a difficult
Mm,
conversation. And so
mm,
I've lost a child to miscarriage, and it's, I'm not going to say devastating, that's a big term, but it is hard to hear this, I guess, spoken about in a kind of removed way when we are the people that we're talking about, right? I mean, it's a reflection of what I shared before, but again, I need to just, I feel compelled to share that because I don't want to overlook like our presence, our true presence in these efforts. We bring ourselves, our families, our experiences to this space, and we're all trying to create safe, welcoming, inclusive spaces through health equity efforts. So thank you for letting me offer that feedback.
yeah. Thank you, Mandy, for saying that. Yeah, that will sit with me, and I will change the way I open this presentation in the future when I've got a chance to work with folks on this. Thank you for that. Linda, and I also just, if you hadn't raised your hand, I was going to call on you. I wanted to know more about your question in the chat. Linda, are you able to come off mute? All right, we'll come back to you. Let us know. Christina.
Yeah, hi, it's Christina from Hawaii. One of the things when I was reading the New York Times quote that you had, there's an
Mhm.
underlying current in that I think is worth noting, is it's like they don't care.
Yeah,
Oh, because they're smoking, they don't care.
yeah,
And I hear that a lot as an undercurrent. Of course, they don't say that, but I think we need to be really careful about um that coming. It comes through loud and clear. I feel like, whereas sometimes I've noticed when communities that I've worked with, when they understand that it's an issue, sometimes they don't. People I've worked with, they maybe don't equate a habit with the outcome sometimes. And so, do they know that this is an issue? I don't know. How do we know unless we include them in the solutions? And so, yeah, I just want to make a note of that. Thank you.
yeah. Yeah, no, it's definitely, and some of the mental models that are operating on, like the othering that happens on this health topic in particular, right, is really around the models of the woman as vessel, right, where that's the thing that's important is inside, or as gatekeeper, right, where the woman's responsibility is to ensure that nothing harmful, right, gets into the womb, into the baby, and you keep out the harmful stuff and let in only the good stuff. And when we, model the people experiencing pregnancy in those very narrow and dehumanizing ways, right? Then it's much easier to get to to a statement like that. Like, you know, just every time I look at this quote, it just blows my mind. I'm like, what editor let that out the door, you know? But it does, you're absolutely right. It does speak to kind of the underlying level of the underlying assumptions, right? I mean, a linguist would call that a presupposition cue, because it shows the assumptions, right? It cues up, it makes explicit the assumptions that you're working from underneath. All right, Linda, I'm glad you're back. What's up?
Sorry about that. Or someone
No,
knocked on the door
all
as
good.
soon as you
Yeah.
said something. It much in line with what you're describing. I was just thinking from like a tactical perspective, like so many of the assumptions and the framing is like implicit. And so I could imagine kind of saying what you've said to all of us here to maybe a less like receptive audience and having folks be like,
Uh-huh.
you're just like assigning motivations to things or, you know, so how it's so this is a little bit like meta. How do you like
Yeah.
help people understand that these are like dominant narratives that are like showing up all over the place and how we talk about these things and like help them connect it more to like the worldview or the mental model piece? Because I'm trying to think through like strategically how to bring this back to like different groups and convince them basically that like there is actually like framing happening here that has like damaging impacts on the folks that we're trying to work with and support.
Oh, that's a tough one. Nico, if you've got thoughts on that, I encourage you to help me out here. If you want to join in. But let me make sure I understand your question, Linda. You're imagining, right, that I don't know. Tell, like when you think about a group you're imagining of taking it back to, can you give me an example maybe?
Yeah, like, you know, there's kind of it's like you're talking to folks who maybe I mean we see how rhetoric whatever way you want to
Yeah,
talk about it
yeah,
rhetoric or um propaganda or just framing
yeah,
in media and all these things so like take some of the pushback against even talking about equity and
yeah,
um so much of that has become like implicit it's very strategic and intentional for many folks but then for a lot of folks who kind of are just being trained up through this like dominant like paradigm
yeah,
or worldview,
yeah,
how there's like not a recognition or realization that there is framing that's operating that has these
yeah,
assumptions in it. And so if you're trying to help people kind of build their capacity to like identify like the
yeah.
problematic framing or the disparaging framing so that they can come up with like new framing, like are there strategies for how to do that so that you don't get people being like, I don't know what you're talking about. We're just being factual. We're just telling it like it's happening. And
Yeah,
you're
yeah.
just trying to kind of create this storyline.
So I think a couple of things. So I think that using framing as a tool in your work, and then and sharing it, it's helpful. I find it's most helpful to make sure you're always sharing it with your fellow framers, right? People who are trying to tell the kind of story you're trying to tell and advance that public health and justice oriented point of view. I don't talk about framing to my framees, right? The people that I want to, that where I know I've got some mindset work to do. And so eventually, right, if your framing has been successful, your framees might become some of your framers, your fellow framers. But you know, it's almost like you have to do you need to do that influence first before you include them in your strategy. Um, I think once people have been introduced to the idea and you get people to look at language, you tell people like, you know, my concern is that some of the ways we're talking about this is inadvertently, and I always say inadvertently, although sometimes I think it's perfectly intentional, but so we're inadvertently reinforcing ideas that some people are less than, or that the root of the problem are people's behaviors and choices and values. I would much rather, I think we've got a higher leverage point in changing this issue if we kind of look upstream, look outside, look more structural. So I want to make sure our language matches that. Like, you can make an argument like that in a public health department. Now, the epidemiologists, God love them, the scientists, the folks that are doing the deep data, that I think with that group, it's a different argument, right? It's not that, hey, you're blaming folks. For the scientists, a science argument. Science does not speak for itself. I want to make sure the science you're sharing, right, comes through as intended, and you show them some data. I can give you all some bar graphs or something. It's like, if you say it without that, right, you get the opposite reaction, right? Scientists really hate the idea that the science is going to be misconstrued or misinterpreted or misrepresented. So that I find is the better argument for those types of colleagues. I hope that was a little helpful. I'll keep noodling on that though. That's a tough one, and that would be a great TA call to try to hash that out as you're thinking specifically about folks you might want to bring in. Dory, thanks for waiting to
No worries.
patiently.
I think a lot of what people have said have been really useful, but I think sometimes, as much as we want to upstream some things are not always able to be. And so we also have to look at, like, I'm hearing some of this, and I can tell you, as someone, I have part of the reasoning behind my disability is because of the care that my biological mother was able to be given due to her life's circumstances. And consequently, those led to my disability. And thinking about some of this, how we frame it and how someone's going to read it is quite important, because the goal shouldn't be blaming and shaming. The goal should be uplifting health and health equity. And sometimes I think in messaging, we lose sight of that, and it becomes very detached and very unintentionally biased. And when you read it, the person receiving that information, are they going to actually, is it going to make change in them if they feel like they may be being blamed for something that they themselves could not have changed? It's not everybody gets equitable opportunity. Not everybody gets the opportunity to have good health education. And I send that out because even me looking at the presentation, I use plain language. I am somebody with multiple degrees who has degrees from Johns Hopkins University. And some of the language in this is not plain language at all. But the assumptive is that everybody in public health knows what all of these verbiage are.
Yeah.
And then what do you do with that if it's not in words that everybody can absorb, understand, and utilize? How do we truly move the needle to true health equity?
Yeah, if we're not making sure people can participate in the conversation, then we're not doing health equity, right? So in its fullest sense, because we're not making those decisions and developing that work in partnership with the people it's affecting. So that's a really excellent point, Dory. Thank you for that. Okay, well, I think I'm gonna give you guys this resource here, which is hot off the presses. This is going to be published soon, but hasn't been published yet. And it's a little bit of a lot of the strategies in these slides. You'll notice a couple of the examples, but one tool you can use to share that, and we'll make sure it comes, with the materials afterwards. And I will now turn it over to Dorothy for the evaluation. Oh, wait, hold on. One more thing to say, which is the next session. Unless the people rise up and request a different topic. This was my read of what people were most interested in. Talking about how to talk about vaccination. So that's our next topic, and now I will turn it over to Dorothy.
Thank you so much, Julie. And thank you everyone for engaging in the discussion, and you queued it up really well. So we have 5 minutes here for you all to complete the survey. So there is the link in the chat right now. You may also contact me, and I will put my email address in the chat right now as well. If you would like to do the survey over the phone with me or receive a Word document to complete the survey, but we really do value your feedback and want to make these sessions the most that they can be for you all. So please do take some time now to complete the practical application workshop evaluation for us. We do review them and act on them as you saw. And then we look forward to seeing everybody next month at the same time. And then again, keep an eye out for our September newsletter. There'll be lots of stuff coming to you in that. And then we will also include this item that Julie shared along with the recording in there. So I will stop talking now, and you all please feel free to sign off after you do the evaluation, and we'll see you again next month.